You're listening to the Physio Matters podcast in association with the MACP, and this is session 10. Welcome back to the Physio Matters podcast for session 10, which is our second podcast in association with the MACP. Huge thanks to your emails, reviews and tweets following session 9 with Dr. Richard Bennett. For our landmark 10th episode, our computer geeks have done the stats and have confirmed that we've now gone beyond a direct reach of 25,000 listeners. 85+% of you are UK clinicians. 20% of you listen to each episode more than once, yet only a measly 4% of you are on Twitter. So get online, you certainly won't be disappointed. We'd love to hear from you. Today's podcast guest is Anne Gates, who is a clinical pharmacist by trade and well known internationally in sport and exercise medicine for being an advocate of exercise promotion through her innovative company, Exercise Works. It's generally accepted in MSK and sports physio that exercise-based rehab is our fundamental treatment modality. So following on from session 9 with Dr. Richard Bennett, I imagine that your patients are now raring to go or in an improved state of readiness for exercise promotion. Be sure to tune in at the end as I reveal our plans for future episodes, as well as a plug for a very special physio and fan of the show who would appreciate your support, I'm sure. So I'll see you at the other side of the interview, and just to give our guitarist a bit of a rest, here's some music that Anne provided for us.
I like to move it, move it. I like to move it, move it. I like to move it, move it. Yeah, I like to move it.
Hi Anne, would you like to introduce yourself for the listeners?
Hi, good morning. My name's Anne Gates and I'm the founder and director of Exercise Works, and I'm a passionate global advocate for physical activity for every consult and using exercise medicine as an important treatment paradigm with patients.
Fantastic, and I'm sorry to immediately stereotype, but a few pharmacists that I've met are passionate advocates of exercise as medicine and are instead more passionate about, shall we say, traditional medicine. So what is the clinical and personal journey that led you to this?
Obviously, as a clinical pharmacist, I'd spent 10 years working in hospitals and 10 years working in primary care, and then moved into a much more strategic role within the NHS. And obviously being trained as a pharmacist in pharmacology and physiology and how medicines actually work on the body, I actually see exercise as a medicine and as a traditional medicine. So although obviously I'm an advocate of safe and effective medicine taking, in conjunction with exercise medicine for patients, I think that almost completes the medical toolkit that we have available to treat patients effectively.
Fantastic, and I suppose that was the wrong wording for me. The most traditional medicine of all is exercise. But do you feel it is a fair stereotype for me to make? Do you feel that the pharmaceutical and medical industry generally does under-promote exercise and over-promotes more tablet-based forms, for example?
Yes, no, I would agree with that. I think that we've yet to discover the benefits of exercise in comparison with medicines. There was a brilliant study done by NACI in the BMJ, which was one of the first systematic reviews of the cost effectiveness of medicines versus exercise. And I think that shocked a lot of people, because obviously you're never going to get a head-to-head trial with a drug company and exercise at the same time. And so that our whole healthcare system isn't actually designed at the moment, and I say at the moment, to see exercise as an equal medicine with, say a tablet form or medicines and drugs in general. But actually, it's this whole new emerging science, because once we start getting clinicians thinking of exercise, thinking of the pharmacological effects of exercise and why something works, and along the lines with physiotherapists, why certain exercises work best with certain diseases and how that promotes health, then I think that we can establish exercise medicine as not only an adjunct but a comparable partner in the prevention and treatment of disease.
Absolutely. And what is it in terms of your story or your timeline, shall we say, that brought you to this point?
I think that's interesting.
I'm
I mean,
sure.
obviously, I'm passionate about pharmacy, and it's ranged from me being a Saturday girl at the age of 13, working in a pharmacy and not even realising that I was going to grow up and be a pharmacist.
Right.
But also having had a very successful clinical career over nearly 20 years in the NHS and being taught by some amazing people at the Derby Royals Hospital. But also moving into that much more service delivery, patient-focused approach to medical care, and identifying that was something that was very important to me, which resulted in me becoming the head of health strategy for Trent Strategic Health Authority, which was a huge career development for me, but had culminated in a lot of opportunities to expand my knowledge, expand my experiences in previous jobs. And I then went to become a director of strategic planning. And actually, planning is what I really enjoy doing, planning services, planning to improve health services. And I did that in a mental health trust. And actually, I didn't like that type of work. And it caused me to have some time out and a career break to reflect on really where I wanted to go. And I was fortunate enough to take that in Antigua.
Lovely.
With my family, and I learnt to sail and windsurf, and obviously, it was very sunny, and I came back incredibly healthy. But there was one key incident that happened when I saw a group of kids playing basketball out there, and despite the poverty in that area, they were able to share fun exercise with their friends and family. And it made me realise how important exercise was as a medicine, not only personally, but to other populations as well. And so I came back and immediately identified that there was a huge gap within health service delivery around exercise medicine. Which led me to then train as a personal trainer, chronic disease exercise specialist, and then also as a cardiac rehab instructor. So, that journey has been, quite interesting, and has brought me to, the fact that now, we launched our company in 2011. And since then, I now work with architects and designers and, other exercise specialists and sports and exercise doctors to ensure that service, that quality of giving safe and effective exercise advice is best served for patients.
So as the world, and particularly Britain, descends into what we could call an inactivity crisis, consistently rising rates of chronic illnesses, what do you think it'll take for society to turn a corner?
I think we're at crisis point. I mean, many people don't realise that physical inactivity is the world's fourth biggest cause of death. And I think that with rising obesity rates and the rising burden of chronic diseases, we're at epidemic levels. And this actually has occurred without much medical input. It's caught many nations and many communities unawares of the situation. And I think that, you asked what will it take? I think it takes action. I think we've really got to take stock of the critical point of which we've reached within the health service system, and to identify a very clear strategic course of action around physical activity and the promotion of better lifestyle habits under the auspices of making every contact count. Making every contact count, to me, is the framework to enable every healthcare professional to be all hands on deck and to provide patients with safe and effective exercise advice, to signpost them to local opportunities within their communities, but also to support patients as we would do a medicine. I always say, if somebody was asthmatic, they'd have an asthma inhaler and we'd support them. So if you look at inactivity, just for this point of conversation, as an asthma inhaler, we wouldn't give them the inhaler and expect them not to know how to use it, or support them and monitor them on that. And what's worse is, with exercise referral, we wouldn't take that inhaler away after just 12 weeks of treatment. So why do we assume that exercise medicine is a quick fix? And because it isn't, and we need to be focusing our expertise on a sustainable future for making every contact count with physical activity.
And if we think about that historically, how do you feel, or why do you think that that's come about?
I think that came through a lot of changes. Without getting too political, I think the NHS has gone through tremendous upheavals. And I think that the networks, the strategic networks, were damaged as a result of that, but also people's capacity to deliver something extra that is just as life-saving as, cardiology stenting. It was missed, and they were focusing on much more interventional approaches to healthcare. And I think that, when you've got a crisis, you have to sit back and say, why have we got this crisis? Who can contribute best to resolving the crisis? And what resources and personnel do we need to help us to achieve better quality patient care? And so I think in hindsight, those key decisions and solution opportunities were missed and have been missed over the last 10 years. I've certainly seen in the last 3 years a rapid appreciation, at public health levels right down to individual clinician levels, of the understanding that exercise, is a very, very powerful pharmacotherapeutic agent. And I think that message is the turning of the corner. I think that's where we're able to empower our healthcare workforce to achieve that sustainable improvement in healthcare.
Brilliant. And myself, Choose Health as a company, the podcast sponsors, which are the MACP, and of course then our governing body, the CSP, all huge advocates of making every contact count. But what would you say makes an effective brief intervention?
I think a brief intervention to me is short advice, but it's embraced by what I like to call a teachable moment. And a teachable moment was a phrase introduced by the All-Party Parliamentary Commission on Physical Activity. And I really like this phrase of teachable moments because to me it embraces that concordance you have with a patient. So their involvement within their treatment decisions, but also that knowledge sharing, that knowledge transfer within a consult, to me is absolutely critical as part of brief advice. So for me, making every contact count an effective intervention is providing the patient with the environment to talk about physical activity, but also to be very confident in your own knowledge as a clinician and identify which exercise programs might be suitable for a patient, not only in prevention but treatment, and to be able to signpost them to those opportunities. But more pivotally, to be able to say to a patient, this is a medicine that I'll be monitoring, just as I would monitor your medicines, the drugs that you're taking, I'll be monitoring the effects of exercise as part of your treatment. So linking it into blood pressure monitoring, lipid levels, and things like falls prevention and work and things like that. So I think to me that is that nugget of excellence in patient care is providing teachable moments around physical activity.
And educating and empowering the clinician is where you feel that starts.
Well, we mapped the whole process of exercise medicine from the patient feeling a symptom to going to see their doctor or accessing hospital services. And so we feel that whole concept of interventions is a whole systems approach. So, for example, exercise medicine needs to be part of every care pathway. And just to give some sort of context to that comment, out of the 2 million cancer survivors in the United Kingdom, 1.6 million do not reach the recommended 150 minutes a week of regular exercise. Now, to me, that's a huge problem. Clinically, it's a disaster because we know that exercise is incredibly effective both in the prevention and treatment of cancer care patients, but also in some cases, such as bowel cancer, it significantly reduces the risk of reoccurrence. So I think that we've got to look at our brief interventions not only in an individual context and understand what environments are barriers and solutions to that, but also in the wider strategic context context of, for example, are our communities fit for purpose for delivering physical activity opportunities for all?
And so it becomes broader, and it does, although we won't get into the politics, it does become a more sort of council-led and broader than just us clinicians.
I think it's council-led. I think it's community-led. I'm a great advocate of people power and of patient power, and I think that that's something that we've underestimated in the physical activity advocacy movement, and mobilising healthcare staff to join that movement and to enable us to see movement is medicine is incredibly important. And I think that goes across all aspects, councils, hospitals, education, or planning of roads and active transport. It's something that as health professionals we should be hugely influential around.
And we're staying on every contact counting, but if I was to just put a different sort of spin on it, for years it was thought to be logical that informing smokers of the risk associated with the habit would inspire change almost through shock. And this fell dramatically and famously short. So might some of us be making the same mistake by nagging people to exercise and trying to use scary statistics once again?
To me, it's about clinical practice. I don't think there's anything scarier than not offering exercise medicine, which is a proven, it's a proven evidence-based therapy to patients. And so to me, I sort of turn that on its head and say, if I was a cancer patient, I'd like to know that the evidence for running versus walking, for example, in breast cancer care is stronger. I'd want to be maximising my best opportunities and options. And so I think that this is a critical part of our duties within that consultation to advise patients on that support and to have an open conversation, a dialogue with the patients on what physical activity imparts to their disease and their health outcomes. So I don't think it's about nagging. I mean, if somebody takes an antibiotic and you tell them to say, take it 1-3 times a day, that isn't nagging. That's you using your expert advice to make sure the patient takes the medicine as safely and as effectively as possible. And I think we need to use that same paradigm around exercise as medicine.
And in terms of the best ways in which we can instigate change in routine, because I quite agree with you, however, it is easier to motivate someone to take a tablet once a day than it is for them to exercise for the recommended amount of time in a typical week. So where do you feel you sit in terms of the best way in which we can instigate that?
I think motivational interviewing is very important, but I think that, we mustn't let that take up huge amounts of time within the consult. We should be effective clinicians. We should know the evidence, we should know our patients well, and we should be able to resonate our advice with what they're already thinking. Around maybe walking just that little bit more, maybe fitting in exercise as part of their day, taking the stairs more often, parking the car, further away when they're on their journeys. And I think that, the whole science has been built up about motivational interviewing, which is very important. But I think with practice, clinicians are very skilled at getting patients to, go for surgery or go for radiotherapy. And so I don't think we need to, this is nice, it's almost busting the myth. I don't think we need to sort of cloak this in motivational interviewing science. I think we need to be effective as clinicians and confident and be able to advise patients on what is the best course of treatment for them. I firmly believe, looking at all the evidence, and I immerse myself in a lot of the evidence that's available around exercise as medicine, and I'm quite convinced that there's a lot more information to come out around the role of inflammation and how exercise modulates inflammation in a whole variety of the major causes of diseases and death. And I think that one of the opportunities that we've got at the moment is to identify the skills needed to make those brief interventions as effective as possible. And so it's about using some of the knowledge, some of our skills, very effectively within anything ranging from 45 seconds to 3 minutes, which is a useful part of a dialogue. And to me, this is life-saving medicine that could be practiced within a brief intervention. Your ability to help that patient to a more active life may well result in reducing their cardiovascular risks, stroke risks, and risks of type 2 diabetes. I think that we need to recognise, I think the skill that health professionals need to identify is actually to say to themselves, I have got the skills and knowledge to be able to do this. And if I haven't, then to learn those skills very quickly, to be able to deliver that world-class, evidence-based advice to patients.
Of course, and our podcast listeners and, of course, the MACP members are predominantly musculoskeletal physios, although we, of course, encounter a large proportion of the general population who therefore have the comorbidities that we've discussed. What are the key points to push in terms of musculoskeletal health and where exercise sits within that?
Well, I think that, we underestimate that patients have a whole variety of comorbidities, and so it's very easy just to treat the patient's problem at that particular point. But actually, what we try and advocate is actually that lifelong medicine, enabling to put life in those years and add years to life, I think is a phrase. And so if somebody's got osteoarthritis or in an outpatient appointment, or receiving therapy or treatment for pain, we know that exercise is critical medicine in those important circumstances. And I think that every health professional does have a public health role to promote and protect the patient's health. So for musculoskeletal physiotherapists, I would love to see them making every contact count for physical activity, but lifelong sustained physical activity, and also to start challenging some of those concepts around some of the diseases. I mean, I was having an interesting conversation actually with my son, who's a student physiotherapist, around the high incidence of frozen shoulder with type 2 diabetes. And I think we all ought to talk more multidisciplinary about some of those things, because my take on this was, well, is that a symptom of type 2 diabetes? Is it something that, because we know that diabetes affects musculoskeletal health, particularly bone health, but also, why is that? And so I started asking questions in my own right of, well, wouldn't it be an interesting study if, rather than treating the frozen shoulder, we aggressively treated the type 2 diabetes? Would that affect the resolution of frozen shoulder in that particular patient group? Maybe doing lower leg exercises aggressively as part of an exercise treatment. And that has lots of other advantages, because it's distraction therapy, it still maintains people's cardiovascular health and everything else. So I think that musculoskeletal physiotherapists and other allied health professionals, we need to start shaking this paradigm up, the paradigm of inactivity and actually what's causing these inflammatory diseases.
Okay, and I know you work quite closely with the BJSM, who are also big advocates of exercise as the fundamental medicine. And in terms of current supporting evidence, what do you consider the key concepts for us to consider? And again, more sticking with MSK for the moment.
I think it's essential that we use all the sort of treatment forms and modalities that we have around exercise and enable patients to use that as a balanced exercise program, whatever their musculoskeletal problem is, because it is important to maintain and sustain cardiovascular health. So they need to be doing heart healthy exercise for 150 minutes a week, but they also need to include twice weekly strength building, which is incredibly important, not only for musculoskeletal health, but also to maintain balance and also to actually treat some diseases where muscle loss may be a problem, but also to include, range of movement, flexibility, and also balance exercises as well. And so I think that musculoskeletal physiotherapists and other allied health professionals have a unique opportunity to do a health check, recognise that exercise is a vital sign, in their patients as part of the consult, and also to add value to the environment of an outpatient's clinic or a physiotherapy consult, in recognising that patients do need support on exercise as a medicine outside of what they're probably being treated for. It's always useful to know, well, actually, I do need to be walking more, and I can, incorporate walking more. I know it's good for me. And it's, those unique opportunities for an MSK physiotherapist to say, well, did you know that there's a local walking group nearby? Or, are there opportunities in your local community that you can access? Because they understand the patient's circumstances the best and are in a unique opportunity to add considerable value to the whole concept of health delivery.
And that brings me really nicely onto the fact that there are so many types of exercise for patients. And although we want to try and promote the general, there are often associated healthcare modalities which are more popular, such as Pilates, yoga, the home exercise programs that physios often get, and they're associated with general health and fitness. And yet there are some forms of exercise more associated with maybe danger or risk. Climbing, skiing, and even recently cycling's been run through the mill. And so it's a question I'm sure you often get asked, but what type of exercise would you say is best?
I think the most important thing is to tap into what patients have already done. So things that they might have done in the past that they've enjoyed, things that they'd like to try, things that might be quite adventurous for them as well. That often is a fresh approach to a patient to get a clinician support into trying something different in a supported, and safe environment. And so I think that's the most important thing is to personalise the exercise prescription to not only the patient's disease, and I think that is quite important. So, for example, for Parkinson's disease, knowing that the walking, is incredibly important and is hugely evidence-based in improving a whole range of health outcomes of Parkinson's disease patients is incredibly important. But linking into some of the fun aspects, I think that you've got to make exercise fun. And again, using the Parkinson's patient as a case study, in the United States, they use non-combat boxing as an extremely effective, fun way of engaging Parkinson's disease patients in regular activity. And the company is called Rocksteady Boxing, but they use aerobic, strength training, balance and coordination work as part of non-combat boxing. Now, to me, that's really fun. And actually, for a lot of Parkinson's patients, it's a very social movement. It gets them interacting with others. It gets that automatic expert patient support group already and it's in an environment that's not necessarily clinical. And I think that has therapeutic benefits in its own right.
And so tailoring the intervention to the condition and to the patient needs to be, as we said before, community centred. So in MSK, we could say that finding local groups for people with osteoarthritis of the lower limb, for example, would be beneficial. But as well as us trying to find them, is there a place for us as health professionals to sort of try and promote them and instigate them becoming more prevalent?
Yes, I think there's huge opportunities for saying, well, it's like walk with the doc. Why not have walk with a physio? The Walk with the Doc campaign is really great because it's about doctors getting patients walking as part of walking groups. And I think that there's huge opportunities within physiotherapists to expand on those opportunities and to make those network links with other professionals like exercise instructors, like cardiac and pulmonary rehab groups and various other opportunities. So it's almost to know and be able to signpost and refer patients as well to get the best support for them. It might be that home exercise programs are actually suitable, and in my experience, patients do best with them as long as the monitoring and that sort of sustained support is provided by a health professional.
Because it's sometimes, and I can admit this from my own personal point of view, it is sometimes not necessarily easier, but safer for us to stay in a room and the patients come to us, and to not necessarily expand beyond that. A full diary is one that doesn't allow you the time sometimes to go and advocate a more community movement or groups and things. So how can we best motivate and empower our clinicians that might be listening today to try and go out and be able to branch out? What rewards are out there for that?
I think the rewards, I mean, personally speaking, I can only reflect on what motivates me, and the rewards are in better patient care, better quality patient care, better engagement, accessing a wider diverse of practice, of clinical practice, and looking at inclusivity, ensuring that the patients that just come to clinic are really the tip of the iceberg. And I always talk about changing that sort of paradigm of iceberg drift into a tropical paradise of where our clinical expertise is far ranging and far reaching. And so I think that we need to be careful in our practice of being gender specific. Looking at what age sensitivities there are around certain exercise groups, particularly around ethnicities and inclusion. For example, I ran a local exercise class for a group of Asian women in Derby. And, it was incredibly challenging. They had no understanding or access to physical activities within their daily life. And yet, they were at the huge risks of physical inactivity. And so I think it's about, without sounding, going out to the patients, but I think, with technology and social media and, other forms of communicating with patients and using other people's skills, technicians and exercise instructors and the whole remit of allied health professionals, we can become much more effective in our motivation and in our message that we're giving out. I always say that the best patient is the patient that turns up and says, "Doctor, I need some exercise advice. What can you say?"
Mm-hmm. Yeah, and my fear is that although we all recognise that prevention and reduction is the best form of treatment and to try and get in there early, my concern is that musculoskeletal physios to some degree they're already too late by the time a patient comes to them. We haven't got the time or the chance to reduce or prevent problems apart from in those that come to us. So if we can engage and get out there in the community more to try and almost prevent people coming through the door in the first place, that is only going to be a beneficial thing. But I have to admit, on my own level, that some patients seem more receptive to exercise advice than others, and I feel even I might be better at motivating and encouraging certain groups of patients. And so my question would be, which groups present particular challenges, either in your experience or from research findings, and how might we best overcome these obstacles?
I think it's not about the groups that are difficult. I think it's recognising that we have got a tsunami of ill health and disease that is going to radically affect the health of some very clear groups that are predisposed to those diseases via genetics and the social determinants of health and a whole variety of other modalities as well. And to me, and again, from an inequalities perspective, it's actually addressing some of those groups first and foremost within this call to action as clinicians. So ethnic groups and the biggest risks have already been identified in the fact that young women through adolescent to the early 20s are at extreme risk. They don't access the physical activity opportunities that are available, and we need to develop physical activities that suit that particular age group and population group the most. That they're one of the biggest risk areas at the moment. Obviously, care of the elderly, with a burgeoning elderly population, we need to ensure that older adults are living fulfilling lives, are able to feel mobile and free from disability and ill health, to enjoy living daily life. And so there are some key things. But to me, I find it very difficult because I feel that we've got to deliver this exercise medicine as cradle to grave. And to me, that's the thing that resonates within the NHS is that every opportunity. So if you're a musculoskeletal physiotherapist, maybe seeing a young athlete with an injury, it's actually ensuring that them and they themselves act as advocates for regular physical activity that is safe and effective, and that or seeing an older person with osteoarthritis, that you provide them with the services that are going to achieve lifelong better health, and to me that's the key for this unique opportunity as clinicians. Musculoskeletal physiotherapists are experts in their field. That opportunity, that unique opportunity to give effective brief advice is essential in changing that paradigm of physical inactivity. And so for me, it's having that concept of being cradle to grave, making every concept count, but actually excelling clinically in your abilities and your motivation. So just as you can get a patient to go through some very progressive musculoskeletal exercises, we need to be again progressing patients through a starting point of physical activity to actually becoming more physical activity, to then seeing exercise as a routine part of their lives, and then maybe, hopefully, engaging in sport and leisure activities that are by choice, not by prescription.
Exactly. Yeah, making the patient make that call themselves based on the fact that they should enjoy them. And we've chosen the right thing to advocate. And we've touched on it a little bit, but in some circumstances, funding and we mentioned councils and the actual access to certain groups can play a part in what is promoted in certain areas. Should that make a difference to what we advocate, or should really we be just promoting things generally and not letting that stop us?
I think it's very easy to see that funding's a barrier. Public Health and Wellbeing Board have a responsibility to promote and protect public health, but also to advocate physical activity within those communities and for the minority groups. But also, we need to be very careful about what I call excuses, which are reasons not to exercise. And we also need to be careful that we don't introduce those within the consultation as well, and automatically put up barriers or excuses for patients not to just step outside and just take a walk within their local neighbourhood. And I think there's opportunities. Clinicians sit on lots of influential committees and local stakeholder groups and a whole variety of community-led services. And I think that if patients don't feel safe in a park, and they tell you that within a consultation, then it's important that we as clinicians start to address that and start to feed back some of these barriers to the funding agencies, and also to try and promote access for all. I mean, I'm a great advocate of just clocking the block, with friends and family, or identifying a neighbour that might help an elderly person. Just take, start with 5 minutes and then progress to 10 minutes of a walking programme within the local community, within their local neighbourhood, or providing a home exercise programme where they can exercise with, just a few cans of beans and doing some strength exercises every day, and looking at those as opportunities and not creating barriers. So I think that with the funding issues sort of parked aside, I actually think we need to be making no excuses and helping our patients to exercise whatever the circumstances, whatever the environments, and actually using our clinicals expertise to help patients break down those barriers as well.
I really like the no excuses, and although it makes me a bit tongue-tied sometimes, I'll certainly be using it. What are the common excuses that are used then and presented? I can come up with a few, don't get me wrong. However, what do you feel are the real obvious ones that seem to be thrown at you?
The biggest one is actually not having the time. And yet, evidence is that people sit watching TV for 3 hours a day, and children, it's often more. So it is about actually being very, very focused on what it is that you want out of your life. A healthy life is what most people aspire to. So it's turning off the TV, or it's, I don't have, I'm at work, I work long hours. It's actually, saying, I don't even have a lunch hour, so I'm not able to exercise during the day, and I'm only exercising at the weekend, which is, like a weekend warrior. And actually, when you start to break down and set some, smart goals for those patients, you realise that they can find 30 minutes a day. And actually, finding that 30 minutes a day makes them more productive. It makes them healthier. They're less likely to have time off work through illness. And so it's about helping them within the consult to realise that they are just excuses. And I'd like to point your listeners to a really great video on YouTube called No Excuses. And, this guy goes through all the excuses. And I won't spoil the storyline because you just got to watch the YouTube video for it, really. But it's really important because you realise that, some of the excuses, when you start to break them down, are actually, solutions to how they can exercise more, how they can access better activities, be it within their everyday life, be it within work, within school, at university. All those opportunities do provide opportunities to exercise. But I think also, as health organisations and as public services, we have to help people to do that. We have to contribute to active transport, improving physical activity within people's lives, and in supported environments as well, that they feel safe. So walk to school groups, helping younger children to access, fun, active play, safely and effectively as part of their development is very, very important. And so, keeping school facilities open for longer in the evening, is shown to improve physical activity by 84%. So it's about us as professionals saying, okay, we might have patient excuses. What are the excuses within our community? What are the barriers that are stopping people accessing a walk in the park, or a walk with their friends and family, or accessing a leisure pursuit that they're interested in?
And often there's certain types of exercise that us MSK physios will try to promote for someone that would love to go for plenty of long walks, but might be struggling to because we're having to pace their exercise because of pain, for example. And we often then would advocate something like swimming or aqua aerobics, and sometimes that can be a bit of a postcode lottery as to what's available, and certainly financially that can sometimes we can hit barriers. Although that is another excuse for a patient to throw back, do you feel like there's a way in which we can best motivate that person to go and find something they can do rather than constantly looking at what they can't?
I think that it's about finding the right exercise, and obviously if a clinician has a high elderly population, then the local community, public services, should be recognising that something like aqua aerobics is an essential service. It's critical for promoting low impact supported activities within older adults with not only osteoarthritis but rheumatoid arthritis. So I think it's about us taking stock of what's available and recognising that sometimes that postcode lottery of access to services needs to be changed, and we're clinicians. We have that empowerment to say, look, we haven't got these facilities in our community. I'm a musculoskeletal physiotherapist. Why not? Because the evidence is this, and this, and therefore, and to use that clinical influence in driving better services for patients, I think is a huge opportunity that musculoskeletal physiotherapists, can start to embark on, and start to really, shake up. We're physios, and it matters to our patients' health. We need those facilities, within our local communities to effectively signpost patients after physio.
And so we are really trying to activate a movement, and it's a call to action, as I think you've mentioned.
Yeah, I like to see. It was interesting. The British Journal of Sports Medicine editor Karim Khan, I had a conversation with him about 3 years ago, and he said, "Well, write a blog. You know, you're very passionate about this. Write a blog." And I hadn't really written, and now I can't stop writing. I love writing, but actually, my first blog was entitled "A Call to Action," and I was shocked as a strategist on how complacent we've become as health professionals in fighting inactivity and obesity. And to me, using my hospital experience, this was like triaging a disaster. It's a call to action. It's all hands on deck. It's every health professional making every contact count around physical activity, and also raising the bar of what we are trying to achieve in terms of health outcomes and healthier lives, in really radically changing our approach within the healthcare system to enable that to happen. And health professionals are qualified to do that. It's within our scopes of practice, so we shouldn't use those as an excuse, and I'm aware that some do. So that needs to stop, and we need to really start becoming the clinical influencers, both at a patient level but also at a strategic level, to answer the call.
So I doubt I'm alone, but a personal bugbear of mine is that some people, some professionals even, would play down the exercise as medicine push. Retorts such as exercise doesn't solve everything are often heard. However, my opinion is that the vast majority of cases, if the appropriate timeframes, variations, pacing strategies and some adjunctive methods have been applied, then things like surgery or medicalisation needn't take hold. I find patients often then consider themselves beyond help or beyond the help of exercise. Do you think it's fair of me to say that, or do I need to get over myself a little?
I think that again, it's about changing that paradigm. I think it's absolutely critical that we advise patients on the appropriate timeframes and variations, and progressing strategies and adjuvant methods, and to me that the big gap that we have in clinical practice at the moment is that sometimes we actually decondition our own patients. So somebody coming with a musculoskeletal problem, say like for frozen shoulder, will obviously be in pain, but we don't promote within that 3 months sort of time frame of where they might get better through adaptation and biological adaptation, and obviously through therapy and treatment. We need to recognise that we need to keep the whole body healthy. And so that they do need to be walking, they do need to be exercising for heart healthy exercise. They need to be able to improving their fitness. And I think one of the key things, particularly with musculoskeletal health, is this prospect of surgery. And at the moment, I'm doing some very valuable work with some members of the Royal College of Surgeons in Edinburgh about this concept and the importance medically of prehabilitation, of making sure that those patients, despite whatever problem they may have, which actually through regular exercise and may actually go away in that 3 months where they might be waiting for surgery, but actually we help that patient to become as fit and healthy for that operation, because all operations carry risks. And cardiovascular risks, infection risks, and recovery risks. And I think that we ought to be working much more closely with surgeons, and actually, rather than saying, why are we limiting the exercise programs? Why aren't we sort of blasting those open and saying, what are the exercise opportunities for this patient? How can we condition the patient into their maximum health? And often that might prevent the need for surgery or further invasive treatments, but also it's a reflection on those timescales. Would that patient have already naturally, with the course of an exercise program, naturally adapted and no longer needed that interventional approach, or with other services, particularly hospital services. So. I think exercise does solve an awful lot of things, because we can't take exercise in isolation just to a musculoskeletal problem. We need to be saying, we're health professionals, how can we improve this person's health over the next 3 months? Not only their specific problem, but their general health. And to me, that's where the real wins are for patients, because I think when you can engage patients in those kind of conversations and those treatment paradigms, that's where you've made the most difference to patient care.
Knowing what we know biologically and physiologically, it is almost embarrassing that people would be sat on a waiting list waiting for an operation, having failed conservative treatment and failed exercise. And so I completely agree with you there. At best, we would reduce the need for that operation. At worst, you've simply made that patient less vulnerable to post-operative risk. And there's an awful lot of evidence, and I can always come back to the evidence, because as a pharmacist by trade, no one will be able to unpick a paper quite like you, I'm sure. So you know full well that the post-operative risks are incredibly reduced by cardiovascular fitness, one of the most prevalent risk factors, I understand.
Yeah, I mean, people forget that deep vein thrombosis post-surgery kills more people than breast cancer, road traffic accidents and AIDS combined. So, we don't want to be rushing into surgery for our patients. We need to be exhausting, in the clinical sense, all the exercise options and support that we can put into patients for them to improve pain control, to improve some of their symptoms, and in some cases to actually, exclude the need for invasive surgery. And I think that also research is very, very important, but we've got to get the research right. We've got to have head-to-head trials with a proper exercise prescription, not just, 20 minutes twice a week, because that doesn't even fulfill the chief medical officer's recommendations on physical activity. And we need to use the research to identify gaps in the knowledge and searching questions as to, are injections better compared with this type of exercise? Or, does the research show that actually the patient would have naturally got better within 3 months? And so I think as clinicians we have to challenge ourselves on that paradigm. And I think that also we have to be very open and honest with ourselves in accepting that actually the best patient consult is the one where the patient doesn't come back and see you, because you've got them better effectively, and you've helped them move on with their life. And I think that we need to get much more research that shows that, and improving patients' health outcomes, not only in the short term but also in the long term as well. And I think, as a pharmacist, I'm very, very critical of some studies that don't have long-term follow-up, because we don't know, the benefits or the harms to patients unless we do the research. And so that's got to drive it. But I suppose my challenge to researchers out there is, please get it right. Make sure that patients are doing the 4 types of exercise with any research proposal. I don't feel that there should be any research funded in the UK that doesn't fulfil the CMO guidelines. And in fact, only a few months ago, an international paper was produced by some very, very eminent authors that didn't even fulfil the Australian physical activity guidelines.
And do you feel like it is improving, or is as research, particularly in exercise sensors, becomes more prevalent, is people cutting corners more, or is it becoming a tighter knit, more robust entity?
I think exercise medicine needs to come into its own. I think it needs to establish a very clear network of researchers, and those researchers need to be working together and much more collaboratively. I think that we need to be much more gatherers of the information, but also to be very critical of the studies and use that to inform future studies. I think at the moment there's not enough learning about why that particular research question didn't work, and I think that we need to be learning just as much from that as learning from the trials that are, you know, really unequivocal and really very clear on changing practice. I think my major concerns in the research gaps are actually implementation and actually translating research into best practice. And I think that's where the huge hurdle is, and I don't think there's enough research being done around exercise medicine in that area, and I don't think it's being coordinated strategically.
I think that's a great point. It's certainly not a field in which the evidence is lacking. It's just that the movement to actually disseminate that and act on it and push it through with patients is something that we need to be acting on right now. The more research we can do into it, the better the trials, of course, but we don't need to sit around and wait for the research to catch up. We can be advocating exercise on the back of the evidence that's already there.
I think the evidence is totally clear. You know, I mean, as a pharmacist, as a clinician, as an exercise specialist, there is nothing stronger than the evidence for exercise medicine. There is nothing stronger than the evidence that we need to act on the research that's available, you know, and that knowledge. But I also think that every clinician, you know, our prime duty is to promote and protect health in our patients, and physical activity resonates with that so much that, you know, there should be no excuse for us not effectively translating exercise medicine into practice.
Many thanks for your time today, Anne. Is there anywhere or anything you'd like to direct our listeners to, or maybe even just a few shameless plugs for you at the end of the podcast?
Thank you very much. I've really enjoyed being interviewed, so thank you. But I'd also like to give a big shout out to Exercise Works. We aim to deliver excellence in providing safe and effective exercise advice and training health professionals to do that. But I'd also like to give a big shout out to the British Journal of Sports Medicine, particularly Professor Karim Khan, an excellent continuing professional development site called Motivate to Move by Dr. Brian Johnson, who's a Welsh GP, to the British Association of Sports and Exercise Medicine, BASEM, Nottingham University, particularly Professor Lowe and Professor Ian Hall, who are helping develop a very exciting undergraduate curriculum for exercises medicine, and specifically to Mr. Ian Ritchie of the Royal College of Surgeons of Edinburgh, who has been absolutely pivotal on a professional level of engaging physical activity with discussions with some of the Royal Colleges, but also on a personal level, really being a great advocate for physical activity every consult.
Fantastic, and we can make links to these resources available to our subscribers through our show notes newsletter, and I will be directing listeners after our discussion to how to get to those. So again, thank you for your time.
And thank you very much, Jack. It's been a real pleasure.
So that was session 10. Huge thanks to Anne for her time and for sharing so much of her expertise for free on podcasts such as this, blogs such as the BJSM Online, and on Twitter. She's at Exercise Works. All the links and resources discussed, as well as reference to hot off the press exercise medicine literature, will be available on the show notes newsletter. Sign up now and stockpile some reading for the rainy and snowy days that are bound to be coming soon. And as if by accident, the MACP conference, 25th of October, is on exercise, rehabilitation and patient engagement. So have a look online, macpweb.org, to sign up. It'll be a great event. Our first year of broadcasting is coming to a close, and we intend on finishing with a flourish. In the pipeline, we have podcasts discussing the management of whiplash, the use of kinesiotape, and a very special episode for the third MACP podcast. You can also look forward to a new format for a couple of episodes, where I intend on opening our mics to more than one guest an episode, which shall help us to debate conflicting opinions. I'm pretty nervous already. Now, finally, but most importantly, I'd like to make you all aware of a very special physio who I had the pleasure of meeting recently, albeit briefly. UK MSK physio Damien Thacker is currently 32 marathons into a 40 in 40 marathon challenge. That's 40 marathons in under 40 weeks. Now, I've been blown away by the support and following that our podcasts have received. And so if you like what we're promoting and want to show some appreciation, please visit Damien's donation page, on which he's raising money for Sheffield Children's Hospital's Burns unit, who cared for his son 2 years ago. Now, the link isn't a particularly trendy and easy one, but it's mydonate.bt.com/fundraisers/40 in 40. However, I will be posting links to his Twitter feed, his blog, as well as his fundraising page on Twitter, on the show notes newsletter, and as much as I can. So if you are interested in donating, then simply search Damien Thacker and 40 marathons in 40 weeks, and you'll soon find him through Google and through our media. Now, I've only met Damien once and only for 5 minutes. He didn't suggest this and knows nothing about it. But since physiotherapy is developing quite the online community, let's see if we can show some community spirit and raise money for a great bloke and a great cause. He's one of our own after all. Anyway, before I start crying, here's a double slice of cheese from me and Anne to see us out. See you next time.
You've been listening to Physio Matters podcast, discussing physio matters because physio matters.
And I've been chatting to Anne Gates from Exercise Works, discussing how exercise works because exercise works.